I think one of the things that we all heard from both Dr. Brickle and Dr. Willard was that there's different ways to design programs and flexibility. I think an important building block for you as you consider looking at developing a program that meets the need for New Mexico, which I think is the most critical piece of all of this, is looking at the educational standards that are out there on a national level. Dr. Caswell Evans chaired, much like he did the Surgeon General's report in 2000, chaired a panel that looked at educational education programs for dental therapy. And on behalf of the American Association of Public Health Dentistry panel, they developed a standard, curriculum standard both for a dental therapy training program and also a pathway. And I think this really will help us think about the classes, the credits, and the standards of the program. So I'd like to turn things over to Dr. Evans, who's really a leader in this realm.
Yeah, thank you very much. It's wonderful to be here. I think my presentation flows very nicely from the two previous presentations. And just let me give you a bit of preamble to put this project in perspective. It was the Kellogg Foundation that approached me to chair this process under the auspices of the American Association of Public Health Dentistry. And the question that the Kellogg Foundation was asking was, could we develop a panel to, one, assess whether a 2-year curriculum in dental therapy in the United States, based upon only high school education, was that feasible to conduct in an academic setting? That was the first question. Is it all feasible? And if it were deemed to be feasible, how might that be done? Now that was a legitimate question at the time based upon the previous discussions we've had. We've talked about the University of Minnesota program, and the question was asked, that's about a 7-year program post-high school, because it's based upon college graduation, and then it's 3 years of dental therapy. So that's 7 years. Well, to be a dentist is 8 years. So you've got a program that leads to a dental therapy qualification that is really 1 year less than a dentist. Dr. Brickle's program is based upon whatever training goes into being a dental hygienist, and then the additional training to be a dental therapist. So that's the 4-year program, maybe 3.5, whatever. The program in Alaska, as excellent as it is a 2-year program, but it's not in an academic setting. So the question was, and as has been pointed out, the international model is a 2-year training model within academic health settings, training settings. So the question was, could an academic program be put together feasibly in the United States based upon a high school education? And if so, what might that look like? So you have a handout which I'd like to refer you to. I won't go through all of the composition of that committee, but on page S14, I do want to bring your attention to the group that was pulled together to take on that work. Just to point out that there was university presidents. It's in the flyleaf of the white binder. I think you all have that. There were university presidents as part of the panel. A university vice president, several deans of dental schools, other leaders, and all of the other composition was at the level of professor in their academic health setting. And all these names, I don't expect that you might know all these names, but all these are well-known, very august and well-positioned individuals. They were selected and asked to play this role because of the heat that clearly was going to accompany this report, and the fact that a group was even involved in this type of discussion and was prepared to produce a report regarding academic curricula in such a contentious area as dental therapy. I can say that this committee, there were 2 additional deans that were on this committee that literally had to back off of their role because of the heat that they were already beginning to receive from their alumni associations. I try to make it clear to every member who's asked to serve on the committee that they needed to wear asbestos suits, and particularly asbestos underwear, because it was going to get pretty hot. And what we didn't encounter, what we didn't anticipate was the alumni association. The only place where the deans were really vulnerable was on the alumni side. So we had 2 that had to back off. The other point that I want to make very clear is that the project per se was not about advocating for dental therapists. The project was an academic exercise to determine what might a curriculum look like. And we had people on that panel who, I think everyone more or less supported dental therapists, but we didn't have people who were out in full advocacy regalia, because that was not their role. So it was not an advocacy role per se. We all entered into this exercise, going back to the point that Mary Willard made very clearly, that this was not a training program for mini dentists. Well, we clearly understand that these were technically trained individuals in a relatively narrow scope of expertise, but we were not about in the process of training mini dentists. So I think with that as background, I think we can proceed. Okay. So we, as part of our work, we called upon academic experts who had experience in training dental therapists from New Zealand. And New Zealand's been training dental therapists for many years. We brought in an expert from Saskatchewan province in Canada. They've been training dental therapists. Dr. Willard was part of our content expert group as well. To learn from them, we also looked at some of the curricula for the international programs as part of our background. We came to the conclusion that an academic program could be crafted for a high school level student, not necessarily assuming that that candidates would graduate from high school and matriculate immediately into a dental therapy program, but just saying that to matriculate into such a program, all that was really needed in terms of academic preparation was high school education. Whether they matriculated in dental therapy immediately or 10 years later, the academic base that was sufficient would be high school education. So I think we can go to the first slide. Because of the nature of this group, we spent a lot of time on the principles to make sure we understood the principles that we thought were important to what were the undergirding principles behind this curriculum that we'll get into in a minute. And we'll talk, and I should also point out that the curriculum, again, as Mary Willard pointed out, would be competency-based. Now, competency-based curriculum is something different than I was trained in, and I'm sure different than most of us in the room was trained in. It's a curriculum concept that I had to get adjusted to because it's something we use at the University of Illinois. I was trained in an era where, as a dentist, I had to do 5 of these, 7 of those, 12 of these, 10 of something else. Why it was 10 was never, we never questioned it. Why wasn't it 9? Why wasn't it 11? What was the evidence base behind 10? But you had that sacred number. You had to do 10 of these. And once you did 10 of those, you could check that off. Whether you were competent in those 10 seemingly was never, that was a question that never came up. In our curriculum in Illinois and in many dental school curriculum now, it's competency based. So that in theory, if you do it once and you demonstrate all the competencies that are involved with that procedure, in theory, you need not ever do it again. Now, in practicality, you will. But if you're deemed competent, if you do it 3, 4 times, whatever it is, then you're competent. However, if you're not competent, you don't get to 10 and say, well, I stopped. You keep doing it until somebody says, well, this is the 56th time you've done it, and now I think you're competent. So that's the difference. So this would be a competency-based curriculum. So the principles, I think, are important to keep in mind because, again, they undergird the philosophy behind the therapies. So that adding dental therapists to the workforce is intended to reduce barriers to care. That these should be professional education environments to ensure that therapists are prepared to work in the context of a team. Dental students are not prepared necessarily to work in the context of a team. Many schools are moving in that direction. The University of Illinois certainly is. But there are many dental schools where the ongoing assumption, the basic assumption, is that the practitioner will be a private practice above the drugstore on Main Street, USA for 40 years. And the notion that they're going to be in a team, their team is their hygienist, their assistant, and their receptionist, and that's the end of the team. So the curriculum is intended to have therapists who, from day one, understand they'll be part of the team. That health promotion and disease prevention will be core elements of the curriculum. Again, not an assumption necessarily in dental schools. The premise that they will work under the general supervision of a dentist and that they will have established protocols based upon evidence. That the therapist will be working under a protocol. The committee did not spend any time anticipating a scope of service. We assumed that the scope of service would be defined by the jurisdiction, and across jurisdictions there are going to be variations in the scope of services. So rather than spending our time trying to figure that out, we basically embraced the scope of service in Alaska and said that for our exercise, we will assume a scope of service similar to that in Alaska. But if New Mexico or Arizona or New York State wanted to change that scope of service, they could tweak this curriculum accordingly. So we didn't spend a lot of time on that. But that within the scope of service, all of the aspects of the services would be covered by procedural protocols. Next slide. That again, the curriculum and therefore the graduates would be structured to complement rather than compete with other dental professions. Again, the educational program would obviously be geared to whatever the scope of service was going to be in that jurisdiction, avoiding this issue that is still commonplace, unfortunately, in dental education, where you have students who are trained to do this much, but their scope of service legally, the state only allows them to do that much. And we're saying within this curriculum that whatever the curriculum is, that it should be targeted specifically for the scope of service and not overtrain people. The educational plan should be based on best practices and include measurable outcomes. And that within each element of the scope of service, the training and educational expectations for the dental therapist should be exactly the same as that of the dental student. There should be no difference. Next slide. You see, we spent a lot of time on the principles, but the principles really help guide our thinking in terms of then what would the curriculum look like based upon these principles. The programs that prepare dental therapists need to be accredited. Certifications, certificates for completion of degrees may be awarded. That dental therapists will be part of an organized system of care where referrals to patients and the responsibility of care are clearly articulated, as opposed to dental therapists being sort of out there on their own. They're going to be, again, part of the system of care, part of a team. And the dental therapist should increase the capacity of the dentist so that the dentist can do more, and the dentist can therefore work at a higher level of service and be able to then delegate more routine services to the therapist. Okay, next slide. So the competencies are as follows. Assessment and judgment, and Mary just mentioned some of that in her presentation. And that the following services, again, by protocol, would be preventive care by whatever the protocol is, therapeutic care by protocol, pharmacology and emergency management per protocol, and then professional and community responsibilities. So these are the five sets of competencies. Next slide. So the curriculum, again, was designed to be completed in 24 months, however that's defined. Again, we didn't spend a lot of time in that. Some academic settings are on trimesters, some are quarters. We said whatever it is, it's going to be about 24 months. And that would serve as the core of the curriculum. Next. The curriculum is a generic type of curriculum, again, designed to be, it's more conceptual than it is flexible. But because it's conceptual, it's very flexible, and it's intended to be a generic type of curriculum that could be modified based upon the needs or interests or the structure of whatever the academic center that wanted to embrace it. And also be flexible so that it could be combined with a dental hygiene program, could be viewed as a professional career ladder or career pathway. Next slide. Very important that the dental therapy training program be in a setting where access to patients and provision of care is such that a competent clinical experience could be assured. That becomes very important in terms of setting. Is there a patient population base that would ensure a competent educational experience? Next slide. Again, we've mentioned that. Next. Okay. Now here's where and obviously behind each of these is a little bit more detail. So we should keep in mind as we go through these things that this is at a technical level of detail. It's not at the level of detail that would be part of a dental school curriculum. But these are the content areas in terms of biomedical concepts. I won't go through all of the lists for you. You can certainly read that. But again, as you read that, when you think of pathology, let's say general pathology, it's that level of pathology that would be needed for that dental therapist within that technical scope of service to do provide the care that they have been trained to provide. It's not an entire degree in head and neck pathology or full body pathology. It's just that range of pathology that they need to provide their services. And that would be true for all these headings. So that's biomedical concepts. Next. Dental sciences, again, it's the same kind of concept. Within these various headings, what is needed for the dental therapist to do their job within their scope of services. Next. And again, the paper will give you a little bit more detail. That paper comes from, this is the Journal of Public Health Dentistry, in which there are several companion papers as well. that you might want to look at, and there are even papers behind these papers that are available to you. Because obviously there's a lot of detail that is really not appropriate for either the PowerPoint or even the paper, but all this information is available. So dental therapy sciences, again, is a categorical heading. These are the subheadings, and within the subheadings is all the detail in terms of the content of those didactic subjects. Next, basic clinical education must include the formal curriculum with scientific principles of dental therapy extended throughout the curriculum. And next, general education includes oral and written communications and cultural competencies because dental therapists are expected to write clearly, speak clearly, and certainly be culturally competent. There are many dentists who can't speak clearly, write clearly, and are not culturally competent, so these are important, really important skills. And then the telehealth communication, which we have talked about, again, Mary hit upon that we expect that the supervision would also be possible through telehealth communications, recognizing that when the concepts of supervision were first developed back in the day, digital communication was not even a concept back then. And we all know that we could be, we could be scaling Mount Everest and basically doing our job, because I got my BlackBerry right here on my hip. And so when I'm on the BlackBerry, I could be sitting at my office at the University of Illinois. So in that same way, much of the supervision can be handled from a telecommunications perspective. So again, the curriculum has a facet for that training as well. Next slide. Okay. Here's the template for the curriculum. We're just going to run through this quickly, recognizing the big piece concepts. We're going to not get into any of the detail of the coursework, but we'll just lay out the concepts for you. Next one. So the first trimester, fundamentals of dental therapy, cardiology. Again, I won't go through all this for you. Introduction of dental materials that the therapist would be using so that they know about those materials. Next. I just pointed out that in the second trimester we envisioned under clinical dental therapy, that's when the clinical element would start for the therapist. We just determined we would use trimesters as opposed to quarters, but if someone were to do it in quarters, it would be the same type of concept. So this is how we envision the flow of these courses to follow out. Next slide. For the third trimester, then we're into clinical dental therapy 2. Again, the technical, writing and communication, nutrition, and anesthesia. Next slide. More clinical dental therapy is actually clinical services, professionalism, ethics, behavioral sciences, telehealth, as I mentioned before. And we envision that there should be a community prevention project to get the therapists as students out into the community. Again, the project in that course would have to be defined by whatever the academic setting was, whatever the community needs and interests were as well. For the fifth trimester. So the fifth trimester, by this point, is very heavily involved with dental therapy. We thought a dental therapy seminar was perhaps a research project or a reading project. The sixth trimester was, again, more dental therapy and the preceptorship experience. We felt strongly, as Mary indicated, that at the Alaska program and even in this curriculum, we advocated for a 400-hour long duration where the therapist would work in a practice setting under the supervision of a dentist as part of their training and grading process, such that their ultimate graduation was also dependent upon completion of that externship experience. That frankly, at an academic health center would probably involve the necessity of that center developing some collegial relationships and partnership relations with dentists in the community, or FQHCs, or whoever was going to be providing that preceptor experience. At the University of Illinois, we would do that through creation of adjunct faculty positions, bring dentists on as adjunct faculty members. We have in the division I direct, we have some 56 adjunct faculty who supervise our students when they're out in the community. But that would all be part of the didactic training program as opposed to something that would happen after graduation. We thought that was important to have in the curriculum. Next. Oh, I just say, you can do this. That is at a high level of abstraction. I hope that it's not too general for you. But I want to give you a sense that the curriculum is there. The group felt that it is doable, but this is a template, highly generic curriculum that in and of itself is probably not immediately applicable to any one place, because each place would want to tweak it to its own particular needs. The scope of services in any jurisdiction is apt to be quite different. But we felt very strongly that this generic curriculum is quite applicable and should serve any training institution quite well that's interested in going into this two-year model. And again, the two-year model is bracketed in such a way that it could be a career path and linked to other educational opportunities.
Not to put you on the spot a little bit, but could you just give a high-level perspective on the career path and that you guys did build that into the process as well for the hygiene?
Yeah, there is an element in there where we also anticipated what immediately comes to mind, a career path for dental hygiene. So there is a connectivity in our report to how this curriculum would articulate with a dental hygiene curriculum. Again, it's part of just the career path. We thought more of it as a career path as opposed to a career ladder. We felt that a career ladder is too lockstep, and if you get off the ladder, you fall off somewhere from right the neck. But if you're on a path, there are always kind of places you can go through the woods. Because we saw this as a highly versatile position that should be a great entry point, not necessarily an end point, but it could be an end point as well, and should be positioned to work well with the entire oral health team, and in fact the entire health team.
Thank you. Thank you, Dr.
Any other questions or
questions?